I'm going to start with a bit of a story. I wish you all could have been there. Here I am, new to a hospital. Shortly after starting at Royal Perth, feeling like a bit of a fish out of water and suffering immensely from imposter syndrome, our head of trauma, who's a very colourful character, very notable character, grabbed my mobile phone out of my pocket and punched his number into it. And he said, "I'm going to call you at all hours of the day and night. When a trauma arrives, I want you to come into our emergency department and I want you to see how we work and tell us what we can't see." And I was quite astonished at this. So I thought, you know what? I'm in. Let's do this. So one afternoon, it was a Friday afternoon in March. I'd only been in the organisation for less than a month. And a gentleman had presented to ED after having a severe motor vehicle accident. He went through the windscreen of his car, suffering significant head trauma, broken limbs and lacerations on a country road about 2.5 hours southeast of Perth. He was transported to Perth by the Royal Flying Doctor Service and then along with St John to our ED. I was called into the emergency department and a senior nurse took me by the arm, showed me where to stand, told me, "Don't get in the way, I'll talk you through what's happening." My eyes were like dinner plates. I've got this unique opportunity to be presented in our ED and watching these people weave miracles and perform in such a high capacity, in such a high stressful situation. It was an experience I'll never forget. It was amazing to observe them go through their protocols and traumas and how they, through the trauma team, and how they communicated with each other. As we went through and stabilised the patient and seeing people come and go, and the din and the buzz and the noise within the emergency department really hit home to me and the environment in which these people worked. Shortly after we stabilised the patient, we had to make a decision on whether we send the patient up to theatre or radiology, but we needed to know what was going on with the head injuries. So we sent the patient around to get a head CT and we called our consultant neurosurgeon. He's a great guy. Anyway, all the staff, along with the patient, we wheeled the patient into the CT. And many staff came with us. I think we had about a dozen people in the CT observation room. The ED was really busy that afternoon, I remember. I think we were meeting pretty much at full capacity. The results of the scan weren't looking that good. And I remember the consultant neurosurgeon confirmed the scan and wasn't very promising for the diagnosis. He said, "Let's talk to the patient's family. We may have to take this patient to the ICU." And there was a silence within the room. All of a sudden, he turned around and he said to the team, "Has this patient been given any sedation or any type of relaxant? Because this will affect what we're seeing here today." And again, silence filled the room. I turned to the trauma surgeon who I was standing next to, a very experienced trauma surgeon, and he looked at me and he shrugged his shoulders. The registrar who was maintaining the airway piped up and said, "It doesn't appear that he's had any sedation." The decision was made to send this patient to the ICU and let's get the family in and maybe start the conversation around organ donation. Forgive me if I've missed some of the technical points. This happened 3.5 years ago. Anyway, I looked at Dieter, the trauma surgeon, and I said to him, "You obviously keep a record of what drugs." I got the feeling the registrar wasn't sure. "Do you think we should go back and check?" And he said, "You know what? I felt the same thing. Let's do it." So we wandered back into the ED. We grabbed the patient's notes and the drug record, and we could see that quite a large amount of vecuronium had been given to the patient and sedated. Dieter said that we need help to get this patient back up into the operating theatre. We'll talk again to the neurosurgeon. "I need your help. Let's turn everything back on." Wow. Welcome to healthcare. I knew this was going to be challenging and I knew I wanted to be a part of it. After we got the patient back on the track for radiology and back into theatres for vascular repair, Dieter came and sought me out and he patted me on the back and he said, "I want you to ask us the tough questions. I want you to tell us what we can't see. I want you to help us in every way so we can be better for our patients." I thought, you know what? I'm in here. I'm all in. Welcome to healthcare and hang on. And it's been a fantastic ride. There's been plenty of ups and downs. So that story really hit home to me. What was I really coming into in healthcare? So whether I'm in the emergency department and working with teams in there or dealing with general patient inquiries, how does and what does a person like me bring to an organisation such as a hospital? Well, I'm a military veteran. I served in conflicts and peacekeeping operations around the world as a pilot and engineer in the Royal Australian Air Force for 25 years. I also flew for Virgin Australia before volunteering in the workforce as part of the volunteers at Royal Perth Hospital in 2017. We hatched out a bit of a plan with some of the cardiologists to improve their patient outcomes and their team performance. They were good at some things, but they knew that they could be better if they just came together as a team and improved their communication, teamwork and leadership. And this is what they wanted to do. So we hatched out a bit of a plan on the back of a coaster at the Grosvenor Hotel one afternoon, and I started just working on my days off in the hospital. And the executive director came up to me one day and said, what are you doing here? And I said, well, that consultant cardiologist over there asked me to work with the team, and I've just been working here. And he said to me, how much are we paying you? And I said, you're not paying me anything. And he said, we need to talk. I went, okay. I didn't know whether that was a good thing or a bad thing. So anyway, the executive director later, he said, I've got a job for you. Would you consider giving away aviation to come and work with us in our executive team? And you know what? I'm all in. So I jumped. And that's how I ended up at Royal Perth and Bentley hospitals. So as we crack on, we learn more about some of the stuff around human factors, and you would have been exposed to some of the terms around human factors throughout this conference in today and yesterday's session, and particularly this breakout session this morning. So what are you going to get out? You're going to hear a few more stories. We're going to talk about human factors, what it is, what it isn't. We'll have a look at a couple of cases where I've employed human factors in practice with a wider team in our hospital. And then finally, we're going to finish on something really, really important and dear to my heart. That is probably the most instigation part of change is leadership. And I'll leave you with a couple of tips and tricks because, like it or not, we're all leaders and managers in healthcare. But before I push on, I just want to mention that it takes everyone in a hospital, doesn't matter what we do, clinical or non-clinical, to make that place really hum. And one of the beauties of working in a hospital and dealing with human factors and working in an executive team is to working with our non-clinical business teams, our security teams, our allied health teams, not only our emergency and surgical teams, but also our maintenance facility teams, our fantastic catering team and what they do, and also our wonderful nurses that deliver so much help and so much care every day. To work with so many teams and understand how they fit into that big organisation was key for me to figure out how we're going to help our wider healthcare team succeed. So what are human factors? As it sits as a subset, it was really born in aviation at the end of the 1970s and early 80s when aeroplanes were falling out of the sky for nothing wrong with them. So, but here's a definition, and human factors examines the relationship between human beings and systems with which they interact by focusing on the improving efficiency, creativity, productivity, job satisfaction with the goal of minimising errors. Now, this is a great definition which is used across many other industries. And you'll never guess where it comes from. It's actually from the World Health Organization's Patient Safety Education Curriculum for Junior Medical Staff. And I think it's a good one. Human factors really sits as an overarching term, and underneath that sits those non-technical skills which we hear so much about. And more often, and more so these days, we hear the term human performance, as it is bridging across many different industries because people want to perform better. But it's also about ergonomics and system design. It's also about engineering and the way we engineer systems and processes. And it's also really around human-machine interface and the automation management that we deal with in every day, especially in our medical and nursing and allied health games. So you're probably sitting there thinking, well, what's a pilot got to do with all of this? I love this Far Side comic because, I'd actually done this, not so much the fuel light, but made a pretty funny error on a flight deck one day. But you know what? I wasn't ridiculed. I wasn't judged. I wasn't deemed that I was unprofessional. I wasn't fear of losing my job. It was more or less quite a funny learning point. Feeling quite uncomfortable at the time, but when we do feel uncomfortable, the growth that we get from it is exponential. So poor old Frank here, I think he nearly had a heart attack when he heard the fuel light was on. So I do have a background in human factors, in teaching and working with teams for a long time in the military, where we really discovered the term crew resource management, or what you might know in healthcare as crisis resource management, which is often practiced with many teams in the hospital. You know, I did have a chance of working with high-performing teams, combat air crews, special forces teams, and working in the Middle East for many years with UK, Australian and US special forces. Now, these people are technically brilliant, like a lot of our healthcare practitioners who spend years perfecting their trade and pushing for that technical mastery. But what they wanted was the skills to work with one another and the human interaction, because they knew that was a linch point for when things went wrong. Their communication, their decision-making, and how they built situational awareness. So there was a lot to be done and there was a lot to be gained. So we often hear these things called soft skills, but talk to one of the special forces teams I worked with and they won't tell you they're soft. When you have to use them in the heat of the moment, when we're under stress and the healthcare system is under stress, they become quite hard unless you're familiar with them or you've had the opportunity to train, to fail in simulation and succeed in mission, as we used to say. You know, I was also a human factors facilitator and trainer in the airline industry, and we got to incorporate some of the human factors principles and practices into everyday systems and some complex systems. But sometimes we think complex problems need complex solutions, but it's actually the other way around. Sometimes the simplest of solutions can satisfy the most complex of problems. And if we get time at the end, I'll talk about how I was working with a anaesthetist in the UK, Dr. Michael Spiro, on war footing in the UK. They wanted to transfer the number of ventilators from 5,000 to 30,000, and he rang me up and he said, "Tony, can you help us?" More on that later. You know, but I sit here very humble because I'm aware of this comparison of aviation to healthcare, and it's been beaten around for many years. And if I could show you the bruise on my chest from when I first got into healthcare for doctors telling me that it wasn't going to work, that's fine. I needed to know, because what I didn't want is for people to think that here's another person from another industry trying to shoehorn something into a very complex system. I didn't do that, but I knew it was time to get stuck in. So I rolled up my sleeves, and in the words of James Kerr, I started sweeping the sheds, as the All Blacks would say, another very high-performing, successful team. I got to know the staff. I got to understand their work. I worked with them. I cleaned beds. I worked in the ED. I've worked around. I've donned PPE for hours, and I had to experience and what they experienced. So we created a foundational human factors course, and we called it Nexus. And a little bit about this, and you may have come across this before, but we had to create the language and a foundational course to allow staff to identify what part of the basics in human factors and non-technical skills was needed and what could be changed and what could be further developed that's already occurring very well and very well practiced in healthcare. So after 18 months, we did that. We enlisted a whole bunch of human factors specialists in healthcare and we came up with this course. It really bridges across many specialties and experience levels and gives people tangible things that they can take away. And we have a lot of fun in the lessons and the teachings. We throw people in the deep end. They really rise up to the challenge. A lot of people walk away actually thinking more about human factors and even challenging their own practices and team practices. It's been going for 2.5 years. We've created 2,500 training slots. The course is structured on 3 half-day sessions, and we talk about communication, teamwork, leadership. We talk about assertive communication, but we make assertive communication very, very easy. And there's lots of evidence that it's working. We talk about workload management, error management, define some terms, automation management. We look at situational awareness. It's a term which is not really well understood, but there's an easy way of actually applying it. And I talk about the F word in healthcare. People don't like talking about fatigue. And coming from an industry where fatigue was such a risk-managed item, we're really just at the cusp of what we can do. But we've had some great advancements with our nursing and ICU and registrars in our ICU to battle and work through different ways of combating fatigue, especially with what's looming here in Western Australia with the advent of COVID kicking off. You know, we also have a vision at Royal Perth Bentley Group to first start the first healthcare human factors centre for excellence and being able to work with other human factors teams across the country. The Australian Healthcare Human Factors Group with Professor Stuart Marshall in Victoria, Professor Paul Salmon at the Queensland University, the Sunshine Coast, and Sachin Chari in Queensland as well. There's lots of people doing fantastic work, and combining that, I think, is our strength. But, as I talk about this, and this program's been going, what are some of the big organisations talking about in regards to human factors? Like, does it mean anything? Well, here's the World Health Organisation's Global Patient Safety Action Plan for 2021 to 2030, which was released earlier this year. Their vision is a world in which no one is harmed in healthcare and every patient receives safe and respectful care every time, everywhere. There's so much really good stuff in here. You can download it. It's available for everyone to read. And we actually got sent through one of our human factors anaesthetist consultants here at Royal Perth, who's done a lot of work in this space, for us to comment on it. And it was really well received. When we look at all of the terms out of here, there's so much in it, but there's a couple of points I really wanted to highlight here, is that the human factors and ergonomics is the key to creating that high reliability, resilient healthcare systems. And I think the great thing is that they've just put actions down. They turn it into a meaningful document, something that you can really put your hands on. Actions for government is to establish an expert group to report on the ways in which human factors, related principles and training could drive sustained improvements in patient safety. Incorporate expertise in human factors into the design, the purchase, the deployment, the use and evaluation of equipment, devices and information tech, as well as the design of tasks and procedures. There are those people who are willing, and we're actually working with some of these people in the University of Western Australia, bringing them into hospitals before processes and procedures are set up. And also ensuring that all licensing, regulatory and accreditation requirements for patient safety involve principles and training in human factors. We're starting that, which is great. Also we're looking at other things, and particularly, this is a great paper from the National Patient Safety Syllabus of the NHS. What they're looking at here is patient safety continues to be a significant issue in healthcare. It doesn't matter where we work around the world. And a focus here on both quality improvement and academic research. Through clinicians training places a strong emphasis on the safety of the individual practice. It is rare that they or anyone else working in the NHS or arguably around the world receive any education in formal safety management or the opportunity to apply those principles, tools and techniques in creating safer systems. But I argue most of you here today have. Neither clinical or non-clinical staff receive training in systems, risk factors and human factors or organisational culture. So what are they saying here? This syllabus represents an exciting new approach to patient safety, incorporating an emphasis on proactive management, identifying risks to safe care, including systems thinking and human factors. These are new terms for everyone on the front line. You've just got to take them with you. Human factors is introduced with special relevance to patient safety. There's a risk on task management and the role of the human in the safer systems. There's continuing investment in human factors in healthcare across the world, and we intuitively know it makes a difference. And I think we don't need to wait for years of research for this lengthy culture change to prove its effectiveness. And I think just as something to leave with you, there's no other safety critical industry that's waited for years of research to prove that this science actually works. So let's have a look at human factors in application. I'm going to take you through a couple of cases that I've been working with in the organisation, because as a director of patient safety, I got to deal with some of the clinical incidents, and it's some of the cases that really could have brought the organisation to its knees, and how we needed to look after our second victims, the staff involved with these clinical incidents, and support them to be better for the future and for their future patients. So what in this case here, we're looking at in the clinical space, I was asked to investigate a clinical incident in cataract surgery, lens replacement. We had a couple of cases over time where the wrong lens was actually inserted. Now, the background to this, it's very complex, and I'm only just going to brush over it, but our return to theatre KPI wasn't really looking that well, and we had the ability to completely prevent the harm, the minor harm that we were causing to patients when the wrong lens was inserted. I started investigating and looking at a number of similar events, and it was clear that it was a systems issue, and moreover, human factors needed to be considered. Now, remember, as I alluded to before, human factors and the language used is not very familiar as I can see it, and I'm happy to be proven otherwise in healthcare, as it is in other industries. So it was about taking people on a journey and really getting them involved and being that person that was allowed to actually let them discover this in their own way. In the current way, we did investigations, and we had a lot of investigations happening at this time, and we were very time poor with the staff. But what we wanted to do was give power back to the staff that were actually going to change this and make it real. The staff that were actually doing the job, not the leaders or the investigative staff or the clinical managers that would come up with the change. What I decided to do was turn it on its head and get the people who are involved and the people who do this job day to day to figure out the solutions. So when I closely had a look at the process, it was clear that we really hadn't looked at, and it was a process which just evolved over time and had add-ons thrown in there to what we thought would make it safe. So what I decided to do was to do a reverse failure modes effect analysis. Let me explain that quickly. So a failure modes and effect analysis is a systemic and proactive method for evaluating a process to identify where and how it might fail and fall, and to assess the relative impact of different failures in order to identify the parts of the process where the most needed change is needed. You know, it's been around for a long time in other industries, and I'm not sure if it's prevalent in healthcare, but if you want more info, whip over to the IHI website, punch in FMEA into their search engine, and it'll pop up, and there's a great video there. It's a proactive method, but what I used in hindsight was a retrospective method, and this is how it worked. So I had to gather the team, and when you're gathering a team to really discuss and to really get everything out of it, we needed someone who was senior, someone who was junior, someone who was going to disagree with us the most, and someone who was going to agree with us the most. We wanted to get rid of all the bias within the room, but we needed all those specialty people. We had senior ophthalmologists, we had nursing staff, we had project staff, we had elective waitlist surgery staff, we had admin staff as well. We mapped out in one afternoon the entire process and put it on a massive whiteboard. And then I asked them to look at where all the human failure points could exist within the process, from the time where the ophthalmologist grabs the biometry to the time, which I still can't get my head around, we use fax machines in healthcare. I don't know whether some people still use them. I tend to laugh at that, but where the biometry is faxed to the administrative staff, and then it gets put into another system, and from that system it's transferred to another bit of paper, and then that bit of paper gets transposed to a whiteboard. You can see how the process has got a lot of gaps in it. So we identified 9 failure points, and it appears, and they told me this, we over-engineered our process for what we thought was a safer process. And it was easy to see how the wrong lens could easily go in to the patient. And we were transposing information and moving away from the point source of truth and the original communication being the biometry. So it was time to give power back to the team, and they did. They simplified the process and went from 9 failure points to possibly 3. We'd reduced the over-engineering of it. We'd increased reliability. High reliability science had come into play, and some of those people who work in the safety and quality improvement space would be acutely aware of today. We also, by doing this process, we also uncovered other potential threats to safety and within the process. And I think had we done this proactively before the process came into vogue all those years ago, I wonder what would have happened. But here's what it looks like. We've reduced the whole process significantly. We've improved reliability. We've stopped drawing stuff on the whiteboard and quickly annotating items. We've improved our logistics immensely. And even though the team wanted to introduce other parts of the process, we stopped ourselves at each point where we thought we were making it safer and thought to ourselves, how does it make the human do the right thing every time and make the wrong thing harder? Well, it was great to take these people on a journey, and we had a lot of fun in the process, would you believe? So good anyway. The other part that we did was we had to look at our surgical safety checklist as an organisation, because we had a few minor harm cases. But the thing was, our auditing process for how we actually, were we doing the surgical safety checklist, we were 100% compliant. It just didn't make sense. From this person as a pilot who used checklists every single day of my life because it saved my butt at the end of the day and the hundreds of passengers sitting behind me. Checklists were really, really important. So I thought to myself, how could we not do a checklist? So with the aid of the ACHS Improvement Academy and the Quality Improvement Leaders course, I gathered a team of experts and leaders within the hospital to find out why. What were the reasons that surgical safety checklist wasn't being done? Even though we said we were, our auditing was incorrect as well. After months of consultation and input, again, giving explicit power back to the teams, the wider teams, it was anaesthetist and surgeon led, we came up with a change. But it took a considerable amount of effort and time to align leaders throughout the organisation to make sure we're singing from the same song sheet, to give people the power to speak up. And we actually confirmed our confirmation bias, if you like, to try and disprove the surgical safety checklist. We searched the world, moreover, to try and find out whether it actually made a difference in first and third world countries. It was conclusive that there was so much evidence out there that the surgical safety checklist does save lives. And if you've read Atul Gawande's book, The Checklist Manifesto, I'm sure you'll agree. So we even sought input from various colleges, looked at our own processes internally from the time that the patient actually turns up to our hospital to the time they're discharged in rehabilitation. And we found that there was 137 points where items of the surgical safety checklist were actually covered. So what the team did was to really, within the confines of the policy, they changed it and they were supported to do so. Here's our old checklist. You know, it's really clunky. It sits in the patient's notes. It's written in font 6. You know, it's divvied up into sign in, time out, and sign out. And what we found out that the checklist was not being completed less than half the time, or was completed ahead of time. The boxes were ticked. It didn't give value. And as we know in aviation and in nuclear power generation and other high reliable industries, that if checklists aren't working for you, don't use them. Now, checklists are living items. They need to evolve and adapt. And sometimes a checklist can be late to adapt. And this checklist hadn't been revised since 2010. This was last year. It needed to change to keep up with our contemporary practices and how busy the organisation had become. So our nursing teams were fabulous to help us with this and redesign. And we even consulted Boeing International. And would you believe that the reasons why pilots don't do checklists are the same why healthcare staff don't do checklists? They're cumbersome, they're arduous, they take too much time. We don't understand what the checklist is doing. Does it actually provide any benefit to me or the patient? Now, checklists are designed to help make experts better. We don't want them to impede your processes or procedures or your time. And this is what we came up with. This is what the staff came up with. So as the executive sponsor, I was very proud to be able to help these teams and create this. And I think everyone can now see the checklist, because the checklist doesn't sit in the patient's notes and read by one person. It sits on the wall for everyone to see. We've got anaesthetists being accountable and in charge of conducting the sign-in with all team members. The surgeons are leading and procedures are leading the time-out. And our scrub nurses and circulating nurses are leading the actual sign-out. But no one can leave the theatre before that's all it's complete. You know, we're going through our auditing processes to see how we're doing. As long as we're doing better than what we had last year, I think we'll be doing better in improving patient safety. The teams that elected to move parts around within the checklist to make the sign-in more beneficial for the patient and the team. The time-out quicker. We wanted to not make it more arduous. And if anything, we've improved the time for the checklist to be conducted because everybody can see it on the wall. You know, throughout these two projects, we gave the teams the opportunity to learn more about human factors, high reliability and safety systems, to improve their communication, understand more about building situational awareness and the parts of that whole process which impede us to make good decisions. We focused on error reduction techniques, leadership and followership, psychological safety and accountability. Additionally, we carried through Safety 2 approaches and principles and the proactively and continuously trying to anticipate developments in leading to error chain events. And can we adapt this checklist in the future? Yes, please do so. So that's about human factors in action through some of the projects that we've led. And we're seeing where the proof's in the pudding. But our leaders still need to be involved in this to ensure that it continues. I'm about to show you a photo, and I want you to take a quick look at it and tell me what you think. Well, you may not be able to tell me because I can't see you, but I want you to think about what's wrong with this picture. Hopefully you can see the IV pole quickly jammed up against the Magnet on L3 Tesla Toil MRI. Thank God no one was injured in this incident. But when you looked at this photo, what did you see? What did you think? What was your internal dialogue? Did you think about who was responsible, or did you think about the system and the environment with which the healthcare staff operated in? And how did that system let down, or through the individual's practices and shortcuts or whatever, led to this incident taking place? You know, it's too easy to think who was responsible for this. But when we talk about human factors, we think about the system and the wider impacts. But we also think about the individual. And the initial reaction to this was, How are our staff doing? Thank God there was no patients in the room at the time. And was anyone injured? No, there wasn't. When we examined the background and we really took our staff through it and those involved in the incident, we made sure that they were okay and we looked after their wellbeing. But we looked at the wider system and how we actually make it easier for humans to do the right thing every time. You know, there were certain shortfalls and we looked around training and education, our warning signs and our processes. And they weren't as foolproof as what we thought. You know, this happened fairly recently within COVID times, and the hospital was gearing up and everybody was thinking about COVID and getting prepared. We were saturated. So when our task gets saturated and our distractions exist, we're not surprised when things like this occur. If you come from other industries, of course. You know, we're not going to talk about the COVID impacts at this point in time in human factors. We'll leave that for another session. But there's a great can of worms there that we can pull apart also. For me, this is a standout error. This is not a constant error. We're not talking about falls, pressure injuries, drug errors, surgical site infections, nothing like that. This is something which stands out. And really in other industries, it's a telltale sign of something that could be applied across many aspects of business that, you know what, we just need to take care. We need to be doing the ordinary things extraordinarily well. This was a basic thing. It wasn't anything technically brilliant about, you know, having to go to years and years of university to do. So we had to look at what was presented. And then we came across other issues such as attitudes, fatigue, possibly poor training, but also staff deficiencies where staff were taking shortcuts. And you know what happens when we take shortcuts and we get away with it? It sets up a meaningful resolution such that, well, we took a shortcut and we get away with it. It means that we're setting up a new system. We're setting up a new operating procedure because nothing really bad happened. But we're actually normalising deviation away from standard operating procedures. But something like this happens, and then someone actually turned around and said to me, I'm surprised it didn't happen sooner. So that tells us that we were taking shortcuts. So it's soon been rectified. We strengthened our procedures and we looked at our staffing deficits, and we're a lot more robust in our systems on this standout error. So I just want to think and caution everyone here is that when you do have an error which sits out on the side that you think, wow, this was normally a system which is quite robust, what else is happening in your organisation and what else can influence it? You know, throughout this entire change, there's so much that we can do, but as I alluded to before, you know what, this can't be done in isolation by a couple of teams at the front line. It has to be supported by leadership in every way. Leadership is responsible to living that change. And there's a team that I sometimes work with in the States and called Life Wings. It's saferpatients.org. And they go through organisations and help organisations and hospitals, large hospitals in the States, to improve their human factors awareness in order to produce safer outcomes. And they all get scaled and ranked on how they're safe as hospitals in the States. And it's quite a different system, as you would be aware. One of the team leaders at Safer Patients, he said, listen, Tony, he said, leadership is acutely responsible for giving their teams and their people the convictions in order to change their behaviours to affect results. Whatever it is in those convictions, intrinsic or extrinsic motivators, what is it in getting to know their staff in order to change their behaviours? And he drew a dotted line across the page and he looked at me and he said, how many programs have you seen in your organisation where we just try and attempt to change the behaviour to affect results? We get a short-lived change and then behaviours will return. Or those programs sort of peter out and vanish. Or some of them stick around, some of them don't. But he said, look at the ones that stick around and I guarantee you there's a leadership involvement there, a continued leadership involvement. So leadership is so important, but not just at the executive level. It exists at all levels within the organisation. And I tend to talk about a term when I was working, and still work across many hospitals when I work with leaders, and I love working with healthcare leaders. I see it as a mentor-mentor relationship. They teach me as much as I teach them, but we talk about a concept of power over versus power to. And I just wonder whether you sit in this dynamic of do we give power to our staff as opposed to we see leadership as power over. My military training and a lot of investment in leadership training in my military career has allowed me to transpose some of those learnings ever so gently and humbly to our staff and to work with some of our healthcare leaders across many specialties. But I don't want you to misunderstand that human factors is not a behavioural change tool. and human performance is not a behavioural change tool. Leadership is. Leadership sits as a subset of human factors, and it is the responsibility of all our leaders to give us those convictions, to change the behaviours, to affect results. And if it's not working, we need to find out what those reasons are. If we ask the question why, people may not tell us, but if we ask that question, what are the reasons why something's not working, more often than not, people will tell you. So when I do a lot of leadership work with staff and some training with other teams around Australia and so forth, they ask me, Tony, if you had, top 5 leadership principles, what would they be? Here's my top 5. I told you I'd give you a top 5 out of the session today. So number 1, turn up. So it's really hard to lead behind a signature block on an email. And you know what, leaders, doesn't matter where we are in the organisation, we're all time poor. So in March last year, working on weekends as a part of the hospital executive, we're trying to do the best to plan. We're looking at, for COVID coming across to WA, we're looking at PPE stocks, setting up our ICUs, arming our ED staff with the best information that we could find. And I just said to our entire executive team, we need to get out there. We need to talk. We need to quell the fear. We need to just be present. And when you're present, do number 2, and that's just listen. Do nothing else. So when leaders tell me sometimes, I just don't know what to do, Tony, I've got so much pressure on me, and I say do numbers 1 and number 2. If for nothing else, just turn up. It will speak volumes that you've arrived, and listen. Sometimes that's the hardest thing for us to do, and let the silence pervade. And I think whoever came up with the word listen and silent as being an anagram, I'll give them a pat on the back. I love it. So when we're silent, we gather situational awareness and we learn. It is so important for leaders. And I got taught this as a young military aviator in the Air Force. I had a boss who would just let the silence pervade. And more often than not, we came up with our own solutions to our own problems out of those silence moments. Number 3 is role model the behaviours. The easiest thing that we can do as leaders is to just role model what we're after in every way, shape or form, not just in front of our subordinates, but with our colleagues and also from those which whom we are subordinate to in that sense. So everyone reports to someone and we need to role model those behaviours. It's the easiest thing that leaders can do. And when I look at teams, and I had this saying, and it's coined in many different books, there's no such thing as bad teams, just bad leaders. And I think when we work on the leadership and the team at the same time, there are so many things that come to light and so many successes that we can, what we used to say in Special Forces is, there's always the shit that's going to come down the line, but you've got to feast on the good, feast on the good. And, there's moments, especially throughout healthcare in this time, where we can actually feast on the good. So role model those behaviours. Number 4 is move the authority to where the information is. So in complex operations, in complex systems, very, very complicated, what we actually need to do is that as leaders and as managers, we're not going to be able to come up with every time solutions. Sometimes we think because we are in those positions, we need to come up with the answers. If we devolve that decision-making down to where the information lies, and all we have to do is pass intent across, this is the intent of what we want with this change. How do you think we do this? What's the best way? We improve engagement, we improve ownership, and we improve longevity for the change. We move the authority to where the information lies. We let them make the decisions. And sometimes that can be hard for leaders because it's about letting go. But we're not actually saying, and I'm not actually saying you give them everything. I'm saying give them boundaries, set boundaries, give them intent, but let them be a part of that decision-making process. And my number 5 point, if you can already see it, is go back, turn up, C.1. Stick with those 5. And when I've worked with healthcare leaders and some in the chief executive roles, when we do this, we can make an input because it builds trust. And one thing that I love working with healthcare teams is I absolutely love this and worked in a hospital. And one thing I noticed first up is that it doesn't matter what you do in healthcare, everyone has buckets of empathy for their patients. We just need buckets of empathy, especially during this time for each other. And when leaders show that, and I'm working with some senior leaders in airlines at the moment about this whole empathy and how to show this and how to build trust over a Zoom meeting, it's starting to work. And that's one thing our leaders can do. And then finally, when you think the teapot's going to boil over, COVID's looming through the front door, you're feeling overwhelmed, calm is contagious. Calm is contagious. It is absolutely contagious. I learned this the hard way again. a quick story. I was in the Jordanian desert working with UK, US, and our own Australian Special Forces, and I was the only Air Force personnel looking after their close air support or their air support if they get in contact on the ground, and looking after all the resupply that they needed in the war zone. And I was working for this very high-ranking officer. He was a full colonel from the United States Air Force. He was a big, gruff fellow. He stood about 7 feet tall, and he was from Florida, and he chewed tobacco, and he smelt that way. And he said to me, Tony, he said, you just need to slow down. He said, if you're calm, it's contagious to everybody else. Have a look around the room. You've got all these Special Forces team in there. Do you see anyone that's feeling overwhelmed? Do you see anyone that's showing signs of panic? And I went, no. And he said, you need to do that. So I learned the hard way. But walking around our hospital in the height of COVID, I had a couple of people come up to me and say, you know, you just seem so calm. And I'm like, you know what? We may be that duck underwater paddling fast, but calm is contagious, and it works. So here's a couple of tips, but just to really talk about one more thing, you know, a change is hard. You know, I do a change. If I had more time, I'd do a quick change exercise with you to see how really adaptable to change if you are or not, but we might run out of time. Our healthcare staff need this support. You know, when I talk about human factors, and I've got one of our ICU nurse, she's an educator within ICU. She's heavily involved with the human factors program. She came up to me the other day and she said, I've got a bone to pick with you. And I said, what's the problem? She goes, you've turned the light on of human factors, and I see so much more that I didn't see before, and I can't turn the light off. You've opened my eyes to how we can improve things and the littlest things that we can do in the organisation, and it's just so much that I want to do, but I don't have enough time. And I said, slow down. There's plenty of time to change. We just need to support you. And that's a great lesson for us as healthcare leaders to be able to support staff to do that. They want this. There's a thirst for human factors. There's a thirst for change. You know, and it may be fine, as per the cartoon there, who wants to lead the change? It may be just up to you in this safety and quality forum to do so. So, you know, like everything, it needs to be properly resourced and funded, and it does take effort, but discretionary effort only lasts so long for some of our staff. We do need to be able to support them. There are research opportunities, and we're currently working with the University of Western Australia, the School of Psychology. We have a number of human factors, talented experts and researchers coming through, and also from Curtin University to help us map out and look at this longitudinal change. You know, it's not a short-term KPI, human factors. It's not going to immediately plug that leaky hole in the boat. It takes time. But one of the biggest ways that you can measure the change in the organisation, which I see, was that when people change their language, and I had a mental health team leader come to me the other day, and he said, after having done the Nexus Human Factors Foundational course, I now understand what my staff talk about with situational awareness. And I said to him, how so? Well, so recently we had a potential code black. We had a mental health client, a reoccurring patient in our ED, and we had one of our mental health teams managing this patient with security. And it was getting to the point where he was losing awareness of the big picture. One of my team members, he rang me up. I came in. He said to me, I need to remove myself because I've lost situational awareness. Here's the handover. Can you take over? The team leader was scratching his head and he wasn't quite sure what situational awareness was. And afterwards, they really talked about it, but he understood it. And they had a great outcome. They de-escalated the situation. The patient wasn't physically or chemically restrained. It was a great outcome for all involved. And our mental health teams have really changed their language. All of them pretty much have been through our human factors course. And that's how we know that we're getting change. It's maybe hard to research, but I think we need to rethink our approach. We might need to just, you know what, let's turn the bucket upside down, see what comes out, and really rethink and really enlist some people from outside the industry to go, have you thought about this? But we need to do it delicately, because especially in times that we're experiencing now of world change. You know, I can keep going on about human factors, and it's such a human factors theme throughout this conference that we're here for the next couple of days. But I love this quote by Muhammad Ali, and I'm very much a servant leader. But I think for all of those people out there who are in the safety and quality realms, but also in the clinical space and non-clinical space, As a consumer of healthcare that's not clinically trained, I just wanted to say a real heartfelt thank you. Keep up the good work. The general public love your work, and we'll be there to give you support and praise when needed. You may not hear it, but it's there. And likewise, thank you for coming along to my keynote today.